Good morning to everyone, and welcome. In this session, we would like to thank, first of all, TORAY to organize this very interesting session. And I would like to say at the beginning that Dr. Masakane will be substituted by Professor Cantaluppi. And it's really a pleasure to have here also Professor Cantaluppi, and I will invite Vincenzo to start the session.
Thanks, Giuseppe. Good morning, everybody, also by me. And so we will start the first presentation made by my co-chair, Professor Giuseppe Castellano from the University of Milan. The title is Waiting Transplant Patients and Delayed Graft Function, DGF, the role of polymethyl methacrylate membrane. Giuseppe, please.
Thank you, Vincenzo. Good morning again. Can I have my presentation? Perfect. So today we will talk about patient waiting list for renal transplantation and delayed graft function. What is the potential role of PMMA membrane? What we know about our patients is that they are characterized by inflammation. And the fact that in our patient there is an accelerated aging, it is known because our patients are exposed to traditional risk factor of accelerated aging like diabetes, hypertension, or dyslipidemia, or the same uremic toxic. But we have also non-traditional risk factor that can accelerate the senescence. And this accelerated senescence can be strongly induced by complement activation and by coagulation, giving in our patient a phenotype of premature aging. So in the transplant area, we have these patients that are on the waiting list or they are just transplanted and develop a delayed graft function that are really characteristic for a fragile phenotype. This has been demonstrated also by our group in the past that when a patient starts the hemodialysis, there is a complete change in the transcriptome with an alteration, profound alteration in the immune system. So what happens during every hemodialysis session? These things that I will talk you happens really in the early period of hemodialysis. And this is the activation of complement. So complement is activated early in the hemodialysis. This is the C3D on C3 ratio that, as demonstrated by Felix Poppelar, one of my PhD, increased after 30 minutes after the starting of the dialysis session. After C3D activation, C3A, so the anaphylatoxin, will go through all the body of our patient and activate the endothelial cells. So remember this, that every hemodialysis you have complement activation. And in the population, this was a Dutch population that was investigated by Felix, you see that the patient that develop complement activation will have cardiovascular event in the long term because they have a pro-inflammatory phenotype. So this is the reason why several companies are developing drugs trying to block complement activation at the level of the classical, the lectin, and the alternative pathway. And as you can see in this congress, there are several there are several companies that are trying to block complement at different level. And the type of inhibition of complement can be really diverse. So why we should inhibit complement? Because next to a physiological function of the complement system, it has been demonstrated complement overactivated is bad for aging. And this is really present in different organs, like in the Alzheimer's disease, in the brain, or in age-related macular degeneration. So in different organs, when you have hyperactivation of complement, then you have aging. So can the dialysis can we, with dialysis, try to block this process that every day is impacting our patient? You can see here that compared to a classical polysulfone membrane, the PMA has, first of all, a higher effective working thickness. So there is really an adsorption technique that we can use in our clinic. And the outstanding adsorption capacity of PMA, you can see here when you analyze the protein that are absorbed by this filter. And when you compare with polysulfone, there is really a striking difference. So you have really the capacity of absorb this protein. And like BG4NF, you have a strike capacity to absorb pro-inflammatory cytokines, and also, as I showed you, and is known in the literature, the complement system. So why this is important? I will show you that activation of complement is linked to cardiovascular event. And in our patient, in our transplant recipient, the cardiovascular event are present already in the waiting list, and if there is a post-graft failure. So really, our situation, our patients are dealing with cardiovascular events and cardiovascular mortality that are triggered by this component of innate immunity, like complement. But we have data in human. Yes, we have data in human in patients that when in this patient that were used polymethyl methacrylate, they analyzed the 1 year mortality risk in patient hemodialysis. You see really a striking evidence in vivo that there is a reduction of mortality. So if we are capable to remove this component of innate immunity, we can also reduce the mortality in our patients. So it's really effective. Another point that we should consider is senescence. So the senescence of our patient is not only a cardiovascular senescence, but we know that there is a senescence also of the immune system. And we have this manuscript is under review. This is really striking, because when we compare the polysulfone patient with the patient treated with PMMA, and we challenge with the first two deficient anti-SARS-CoV-2 vaccine, you can see really that the response of the immune system to the vaccination is significantly different. And this is the measurement of the total IgG anti-SARS-CoV-2, and these are the specific antibody blocking the site of the recognition. But this is not only in terms of antibody production, but what is also really important is the cell-mediated response. So the dialysis with this adsorption with polymethyl methacrylate can change also the senescence of the immune system of our patient. So reducing cardiovascular mortality, protecting endothelial cells, but also modify the senescence of the immune system. But what about patients that they go to transplantation and they experience TGF? So we know that there are a lot of patients waiting for a kidney transplant. Every year, patients that are transplanted with a mean receiving time of 3.3 years. And most of the time, the organs come from expanded criteria donor. And we have this problem, that is the renal ischemia reperfusion injury, because there is a warm ischemia, a cold ischemia, and that our patients are transplanted. And during the process of ischemia reperfusion injury, there is activation of the complement system that drives also the activation of other systems. Again, as I can show you that there is the coagulation system. And what we can have on the graft is a process of renal aging, because the renal aging is associated with the change in the collagen and with the tubular interstitial aging, so aging of the glomerulus and aging of TGF-beta signaling that is similar to what is happening also in other organs. And when we analyze the process of renal aging, you can see here that matrisome in this beautiful paper is associated with the activation of the complement system. So also in ischemia reperfusion injury, in this patient, there is huge activation of the complement system. And you can see the difference between a kidney that has been preserved with a complement inhibitor or a kidney that has received the ischemia reperfusion damage. So why is it important to interfere also with this pathway? Because you can see that already in that brain patient donors, there is activation of complement with release into the circulation of C5a and C5b29. So there is a systemic activation that can we modulate. But also the complement activation continues during preservation in preservation solution. So this is important because when this kidney will be transplanted, there will be in our patient a huge activation at the blood level of the complement system. So the clinical evidence, this acute kidney injury of the graft is the delayed graft function. This poor function of the graft that needs dialysis, and maybe does not need only one dialysis, but several dialysis until the graft will start again to work. So in this context, it has been demonstrated complement is overactivated. Next to complement, there is a detrimental bridge because we know that complement system can activate also the coagulation system, and this is an aggravation, and this is worse for the graft to have complement system and coagulation that are also activated. So in this new generation of the new PMMA filtrizer NF, you have a special structure in which the coagulation proteins and the platters are not adhering to the surface of the filter, and there is no activation of coagulation. So no complement activation if we dialyze patient with this filter, but also no coagulation activation, because when one of these two systems is activated, it's capable to activate the other system. So coagulation and complement are strictly connected, and we can nicely modulate with a filter with PMMA-based in a new generation. So the thing that we should start thinking about is why not consider a specific dialysis membrane to avoid both complement and coagulation activation without stressing the immune system? Because this is really important. Because I want to report this cartoon from the FABS journal, because our kidney, the kidney that we transplant, are for expanded criteria donor. And as these researchers say, it's like an old cells home in which there are aging cells. If we are not capable to protect the kidney in this really critical point, in this critical period, then all the cells of the grafts will undergo in the senescence, and we will have senescent cells that are really impossible to destroy. So, in conclusion, I hope I show you data that we can give with this kind of technique a modulation of the immune system, because our patients, they have senescence of the cardiovascular system, but also senescence at the level of leukocyte. And we can modulate the immune system, giving a protection to our patient. And what we can discuss is the role of this new technique in removing the complement system and the other pro-inflammatory cytokine in patients in waiting list, but also in the delayed graft function, trying to limit complement activation, coagulation, and to have a reduction of cardiovascular risk of infection, and to have a better graft function in our patient. And I would like to thank you for your attention.
Thank you, Giuseppe, for this very exhaustive and elegant overview on complement and senescence in the peri-transplant period. And you want to introduce?
Yes, it is my pleasure, because we keep the discussion at the end of the session. It's my pleasure to introduce Philippe Rieu for France. Then he will talk about new frontiers in anti-thrombogenic membrane technology and clinical application. Keep the question for the end of the session. Please, Dr. Rieu.
So good afternoon. Thank you for the introduction. So my name is Philippe Rieu. I'm working in the nephrology division in Reims University Hospital in France. And the topic of my talk is the development of anti-thrombogenic membrane. So the first question that I like to ask is, where does the initiation of coagulation during in vivo hemodialysis take place? Is it in the bloodline or in the dialyzer? So to answer to this question, Lucky and collaborator developed an experimental model where there is a bypass here that excludes the dialyzer. And the experiment set was made with two periods. In the first period, the blood circulates only in the bloodline. And as you can see on the right panel, there is no activation of the coagulation because there is no generation of TAT. TAT is thrombin antithrombin complex. And after 20 minutes, they close the bypass and the blood goes through the dialyzer. And as you can see, very quickly, there is activation of the coagulation. So the first step is the dialyzers, but not the bloodlines, activate coagulation during extracorporeal circulation. The second question is, which pathway of the coagulation are activated within the dialyzer? Is it the contact activation pathway that activates factor 12, or is it the tissue factor pathway that activates factor 7? So in this experimental ex vivo models, blood from a transfusion bag goes through different types of dialyzer. And as you can see on the right panels, AN69 gives the highest TAT generations compared with cuprophane or polysulfone. And only AN69 induces factor 12 activation. And furthermore, in the experiment, when they use blood from factor 12 deficient patients, they can reduce considerably the thrombogenicity of AN69. And there were no change with polysulfone and no activation with polysulfone. So AN69, due to its methylsulfonate radical, is the highest, exhibits the highest surface electronegativity of all dialysis membrane currently used, with a zeta potential of -17. And when the surface of electronegativity of the electronegative membrane is coated with PEI, a polycationic polymer, you can reduce the electronegativity of the membrane. And the name of this membrane is AN69ST. So when you reduce the electroactivity of the surface of the AN69ST compared to AN69, there is a decreased binding to the membrane of the factor 12, and there is a drastic decrease of the activation of the factor 12. So when the contact activation, in summary, the contact activation pathway is involved in the thrombogenicity of the membrane of negative charged membrane. But it's not the case of a neutral surface membrane. And what I will show you is that with neutral membrane, the tissue factor pathway is the main pathway that is activated in the dialyzer. So what we did, we show that neutrophils, but also platelets, and also platelet leukocyte aggregate, they adhere strongly in vivo on the membrane of the AN69ST dialyzer during hemodialysis. And when we remove this cell after a dialysis, we show that most of these cells are neutrophils, and that these cells express tissue factors. And more than that, these cells are activated, and they produce nets, as shown by DNA binding, and the net binds tissue factors. And when we remove the cells, these adherent cells from the dialyzers, we have shown that these cells are able to induce thrombotic thrombin generation compared without cells, the yellow line. And this could be inhibited by an antibody against tissue factors, and there were no effect with a control antibody. And finally, using a tissue factors inhibitor, the SEN7AI inhibitor, so using these tissue factors inhibitors, we show that we can prevent clotting in a sheep model of hemodialysis. So there is a clotting without anticoagulation, there is no clotting with heparin, and there is no clotting with tissue factors inhibitors without heparin. Therefore, knowing these results, there are two strategies to develop anti-thrombogenic membrane. One strategy is to use anticoagulant grafted hemodialysis membrane that can present further activation of coagulation induced by adherent cells on the membrane. So this is one strategy. The other strategy is to develop high biocompatible hemodialysis membrane that prevents cell adhesions. And without cell adhesions, there is no tissue factor exposed, and without tissue factor exposed, there is no initiation of the coagulations. So let's start with the first strategy. The coating of the AN69ST by the polycationic PEI explains that it can bind heparin, negative charge molecules. And we show that unfractioned heparin, but also low molecular weight heparin, can bind AN69ST, but not AN69, not cuprophane, and not polysulfone. And using this property, we show in a randomized trial that where we compare AN69ST with half dose of heparin, compared with other membranes that does not bind heparin with full dose of heparin. We included 170 patients, and we performed more than 12 sessions per arm. And finally, we found that using AN69ST with half dose of heparin does not increase the risk of massive clotting in the extracorporeal cut circuits comparing with full dose heparin and other membrane. So therefore, Ospal developed this heparin grafted AN69ST membrane called the heparin membrane with heparin grafted. And the EP0 study, which is a randomized multicenter international control open label study, shows that the success rate of heparin-free hemodialysis is higher, 60.8.5% with the heparin compared with other membrane, 50%. So the first strategy partially worked to prevent coagulations. And there is another strategy, we said, is to prevent cell adhesions using biocompatible membrane. So how to increase biocompatibility of this membrane? One way to increase biocompatibility of this membrane is to increase hydrophilicity. So hydrophilic surface have, as illustrated here, functional groups that are attractive to water molecules by forming hydrogen bonds. And we have and we can have non-freezing water that binds strongly to the polymer, intermediate water that binds less strongly to the polymer, and free water. And the intermediate water and the non-freezing water shown here as bound water. And hydrophilic surface have, in comparison with less hydrophilic surface, a thick layer of organized, well-organized, and tightly bound water. And the structure of water on a polymer surface is a key factor in biocompatibility. So it has been shown that bound water molecules of hydrophilic surface prevent protein absorptions. Here you have different membrane samples with increasing hydrophilicity, and the increasing hydrophilicity is associated with a decrease in protein adsorptions. On hydrophilic surface, the protein molecules cannot melt, displace the well-organized and tightly bound water. And there is no driving force to induce adsorption. And because adhesion of the cells to the membrane is also adhesion of cells to the proteins that bind to the surface, bound water molecules of a hydrophilic surface, it has been shown, prevent cell adhesions. And the more bound waters you have, the less cell adhesion you have, and the cell adhesion strength is decreased. So TORAY has developed a new membrane called HydroLink. It's a polysulfone PVP membrane with a new NV polymer, which has a high hydrophilic and high hydrophilic property. And this hydrophilic membrane has also high hydrophilic property. And experiments from TORAY have shown that adsorption of protein, and for example here it's fibrinogen, it's a black bar, is decreased and it's very low to the HydroLink membrane compared to other polysulfone membrane. And they also show that the binding of cells like platelet adhesion, the gray bar, is decreased, drastically decreased onto HydroLink membrane compared to other polysulfone membrane. And in this small randomized clinical study, there were heparin reduction tests within 5 weeks. The authors show that the success rate of heparin-free hemodialysis was higher with, in the HydroLink group, 50%, but it's only 5 patients among 10, compared with a control group, 25%. So what is a better strategy? Is it better to use anticoagulant grafted hemodialysis membrane or to use high hydrophilic hemodialysis membranes and prevent cell adhesions? So this is my third and last question. To answer to the question, we are doing a control assay comparing heparin membrane with HydroLink membrane. So this assay is a RESTIT study. It is a randomized, open-label, multi-center crossover trial comparing HydroLink and heparin membranes to assess non-inferiority of HydroLink membranes to perform heparin-free dialysis. This is the experimental plan. There is 304 patients should be included. Each patient included have a dialysis with heparin then HydroLink or HydroLink then heparin. And the heparin therapy will be, per dialytic heparin will be decreased in 3 sessions. And the primary outcome of this study is the number of hemodialysis session success without heparin. And the secondary outcome will be the quality of the dialysis sessions evaluated by the KT over V, URI, and beta-2 microglobulin. So this is inclusion rate. So now there is 157 patients that are be included. The inclusion rate was low at the beginning because the dialysis center in France at that period was disorganized by the COVID epidemic, but now the inclusion rate is fine, and we hope we'll finish the inclusion at the end of the year. So, in summary, dialyzer but not bloodline activates coagulation during extracorporeal circulation. Dialysis membranes with negatively charged surfaces induce activation of the coagulation by the contact activation pathway. Dialysis membrane with neutral surfaces induce activation of the coagulation pathway by the tissue factor pathway. Tissue factor is expressed by adherent cells to dialysis membrane. The anticoagulant grafted hemodialysis membrane partially prevents coagulation of the extracorporeal circuit. Hydrophilic membranes, by preventing cell adhesion and then exposition of tissue factors, may prevent coagulation of the extracorporeal circuit. And the RESTED study is a randomized open-label multicentric crossover trial that will compare a high hydrophilic membrane, the HydroLink, to a heparin-grafted membrane, heparin, with a strategy of minimizing the dose of per-dialytic heparin in order to reduce, at the end, the risk of bleeding in chronic hemodialysis patients. Thank you.
Thank you very much. Very nice lecture, Dr. Rieu. And then we keep the question for the end of the session. And this is really a pleasure to have Vincenzo Cantaluppi here on the stage to talk about inhibiting complement activation in septic AKI, why considering PMMA-based dialysis. Please, Vincenzo.
Thanks, Giuseppe, and thanks, first of all, of TORAY for the kind invitation. I really appreciate it. So let's go through the immunonephrology in the critical care nephrology setting and AKI. This is the agenda of my presentation. We first see some epidemiologic data and new pathogenic mechanisms of sepsis-associated AKI. We see the role of the so-called PAMs, pathogen and DAMs, damage-associated molecular patterns, focusing on the complement activation, but also some other molecules, and the potential protective role of PMMA in these events. Starting from epidemiologic data, we know that about 20% of hospital admission develop AKI, and about 1–2% develop a so-called the need of dialysis. This is usually in a context of multiple organ failure, mainly due to sepsis. And the other important point as a nephrologist is what happens after the AKI episodes. We have a risk of progression toward chronic kidney disease. So today AKI is considered an independent factor for the development of chronic kidney disease. AKI, we should not consider today AKI such as a disease, but with a clinical spectrum of the so-called AKI syndrome with different causes in which sepsis represents the most important one in the critical care setting. And then putting together sepsis and AKI, you can see that the addition of the two diseases leads to a length of stay, hospital costs, readmission, mortality during the hospitalization, and development of chronic kidney disease. As suggested by Marco Fiorentino and John Kellum here, long-term survival in patients with sepsis-associated AKI is strongly influenced by renal recovery. These are data from our ICU in our hospital. On the right, you can see sepsis-associated AKI, and on the left, other causes of AKI. You can see applying the KDIGO, the stage 3, the percentage of KDIGO stage 3 is higher in the sepsis-associated AKI and characterized by more frequent need of RRT and progression toward chronic kidney disease. So AKI per se is leads to an increased risk of mortality, but in particular, sepsis-associated AKI increases the mortality risk in comparison to the control group and to other causes of AKI significantly. As Acute Dialysis Quality Initiative Workgroup, the ADQI Workgroup, last year we published this consensus statement in which the definition of sepsis-associated AKI is the presence of both the consensus sepsis criteria defined by sepsis-free recommendation and the AKI criteria defined by the KDIGO guidelines. Sepsis-associated acute kidney injury is an heterogeneous syndrome with multiple mechanisms that can contribute to tissue injury. So we have the relative contribution of one or more specific mechanisms that are summarized in this slide. So we can have different so-called endotypes of sepsis-associated AKI, including inflammation and complement activation, mitochondrial dysfunction, metabolic reprogramming, microcirculatory dysfunction, leading to a subphenotype of patients that can lead to an adaptive repair or otherwise to a maladaptive repair with fibrosis. And sepsis-associated AKI is today considered to be mainly ascribed to the damage induced by these inflammatory mediators, the so-called PAMs and DAMs, that can have two targets within the kidney. The endothelial cells in peritubular capillaries leading to microthrombosis, and so areas of ischemia in the tubular cells, and the direct effect of these PAMs and DAMs on tubular epithelial cells cells, leading to mitochondrial dysfunction, metabolic reprogramming, the induction of cellular senescence, and finally apoptosis. From among the PAMs, LPS is surely the most known, and among DAMs, HMGB1 is the most considered in the study. So basically, we can say that for sepsis-associated AKI, endotoxin may have a direct effect on renal resident cells through the activation of toll-like receptor 4, leading to cytokine, to inflammation and oxidative stress, but also an indirect effect stimulating immune cells to release a plethora of cytokines. And these cytokines, in particular TNF-alpha and Fas ligand, are not only biomarkers of activation of the disease, but they can also bind to specific receptors located on tubular cells, playing a role in multiple organ dysfunction, including immune cell death, and also, in the last here, the induction of tubular injury for the activation of this pathway. Not only the cytokines, endotoxin cytokines, we have other molecules, such as co-stimulatory molecules, in particular the CD40 ligand pathway, that is essential for T-cell activation. But these co-stimulatory pathways are also present in other types of cells. In particular, CD40 is present on endothelial cells and tubular epithelial cells in the kidney. If we stimulate with the soluble form of CD40 ligand tubular cells, the activation of CD40 leads to an increase, a triggering of the release of inflammatory mediators, so sustaining tissue inflammation. And as described in atherosclerosis, the soluble form of CD40 ligand can be released by activated leukocytes and platelets, inducing endothelial damage and microthrombosis. And we know that in sepsis, the levels of soluble CD40 ligand are associated, high level of soluble CD40 ligand associated with an increased rate of mortality, together with, in association with high capacity 2 and lactatemia levels. Last but not least, we already known about the complement, and in particular the activation of the free pathways on the complement, and this may also have a role in sepsis-associated AKI, as demonstrated in experimental models. You can see here in this model of injection of E. coli in baboon, there is at the tissue level, at renal level, the baboons develop AKI, and we have the deposition of complement, the membranous matter complex, C5b9 here, and the decreased expression of complement inhibitors such as decay accelerating factor and CD59. So the activation of complement is also also plays a key role in sepsis-associated AKI, as demonstrated by our chairman here. The activation of complement during sepsis may induce alteration in the two targets that I showed you before, endothelial cells. So basically, through the so-called endothelial to mesenchymal transition, the loss of endothelial antigen and the endothelial phenotype, and the acquirement of a fibroblast phenotype, so leading to capillary rarefaction. And also the activation of the complement may have a role on tubular epithelial cells, leading to a decreased expression of clot, also triggering the so-called cellular senescence, as described here. AKI is nowadays considered a sort of accelerator of kidney aging, with the increased expression of senescent cells and with the release of pro-inflammatory mediators that play a key role in the progression from AKI to CKD. So this is the complete schema of what happens in sepsis-associated AKI. We have seen endotoxin, cytokines, complement activation, a lot of things in this so-called storm, not only the cytokine storm. And so in the second part of my presentation is what we can do with blood purification therapies. Let's see some lessons from a randomized clinical trial in sepsis-associated AKI. We, as the ATKI work group, we suggested this definition for extracorporeal techniques. Extracorporeal blood purification, EBP, can be used to remove pathogens, microbial toxins such as endotoxin, inflammatory mediators, and other toxic metabolites. And the most important thing is that the start of EBP in sepsis might be considered for immunomodulatory support in patients who meet explicit and timely clinical or biological criteria. And today we have the chance to see what happens in the blood of our patients. And the endotoxin is surely the first target for removal in blood purification. This is the study made by Claudio Ronco in Vicenza, the EUFAS study, showing that polymyxin BMO perfusion, able to selectively target endotoxin in the blood, added to conventional therapy, significantly improved organ dysfunction and reduced 28-day mortality. There are different studies have been performed using polymyxin BMO perfusion. This is the last one, the Euphrates trial, in which the authors identified an endotoxin activity level between 0.6 and 0.9 to see a signal of reduction of mortality. We are all waiting for the results of the Tigris trial to see if this is confirmed. And in these very old studies in vitro we performed in Torino with Marco Ranieri group, this is a very simple experiment. We took the plasma from patients and incubate human tubular epithelial cells. As you can see, after polymyxin BMO perfusion, plasma reduces its pro-apoptotic capacity on tubular cells. This means that the hemoperfusion is able to remove some pro-apoptotic mediators, and this is obviously related, as I showed you before, to the reduction of endotoxin, but also, as you can see, to the reduction of cytokines such as TNF-alpha. And this is very important because tubular epithelial cells, to talk about the immunomodulation, is in biological active cells able to induce antigen presentation, and tubular cells are the cells in our body able to remove the cytokines, the inflammatory cytokines. We know that plasma cytokine levels can predict mortality in these patients, and so for this reason, 20 years ago, Claudio Ronco proposed this peak concentration hypothesis, so to intervene with extracorporeal blood purification therapies to modulate the inflammatory response. Polymethyl methacrylate, PMMA, is able to absorb these inflammatory cytokines from the blood. These are some data looking at the decrease of TNF-alpha, IL-6, and IL-10, thanks in particular to the adsorptive properties of this membrane. And some other lessons came from the chronic hemodialysis setting. Giuseppe Castellano already showed the data from Dr. Abe, Dr. Masakane from the Japanese Society for Dialysis Therapy, in which PMMA is associated with a reduced risk of mortality, in particular of cardiovascular events in the Japanese dialysis population. This is probably due to the increased membrane biocompatibility, in particular to the, as we have seen, to the reduced production of anaphytotoxins, so complement activation, such as C3A, C5A, the coagulation system, the cytokines we mentioned before, and also to the limitation of the cellular response on leukocytes and platelets. And Giuseppe already showed you the proteomic analysis in which we can observe the increased absorption of the PMMA membrane in the chronic setting, but this is also true for the acute setting, obviously. These are some unpublished data in which, from our group, in which we observed the reduction of soluble CD40 ligand. I showed you before the activation of the CD40 ligand pathway. These are in the chronic setting, but you can see the shift to polymethyl methacrylate membrane in both group 1 and group 2 is able to significantly decrease the levels of soluble CD40 ligand in the blood of our patients. So keeping all these things in mind with Giuseppe, with the group of Bari and Claudio Ronco in Vicenza, we decided to see the effect of polymethyl methacrylate in this swine model of sepsis-induced AKI with the infusion of LPS, and pigs were treated by hemofiltration using a standard polysulfone versus polymethyl methacrylate membrane, PMMA. What we observed is that in comparison to LPS alone, hemofiltration with PMMA induced a significant decrease of mortality in the experiment in the pigs. And this was not observed during hemofiltration with polysulfone. Not only a protective effect on the outcome, but also an increase of urinary output observed with PMMA. And this means that there is probably a protective functional effect on kidney function. Not only a functional effect, because looking at the histological data, you can see that LPS can induce tubular injury with inflammation in the intestine and the microvascular derangement with thrombosis that is not observed, in particular the tubular injury score, when PMMA hemofiltration was done. By contrast, polysulfone showed the same histological data of LPS alone. And in particular, this histological analysis of the early fibrosis in renal tissue observed in LPS and also in pigs treated by polysulfone, but significantly decreased in presence of polymethyl methacrylate. And this effect may be due to a blockade of senescence, tubular senescence. This is the staining for clotto. LPS, decrease of clotto, that is the most important anti-aging, anti-senescence factor in tubular epithelial cells. And you can see how PMMA can maintain clotto. But also looking at the gene expression profiling study on circulating PBMC, we observed a significant difference between LPS and PMMA-treated group. In particular, PMMA is able to decrease the expression of genes such as granzyme B, activation of the complement, such as complement factor B. Not only at the systemic level, this is the PMMA-induced decrease of activation of both the classical and alternative pathway of the complement cascade, but also the tissue level. If you, for this immunostaining in the kidney, you can see here the membrane attack complex, C5b9, that is upregulated during LPS or during the treatment with polysulfone, but significantly abrogated by the PMMA treatment. Not only the complement, but we have shown before the importance of the CD40 ligand pathway, and PMMA is also able to modulate. As I show you in the chronic setting in patients, there is a decrease of the soluble form of CD40 ligand that has a role in the mechanism. So to end my presentation, the idea is that with extracorporeal blood purification therapies, we can somehow modulate the mechanisms that are associated with multiple organ failure, including sepsis-associated AKI. And today, we have the technology to try to clear from the blood different factors, different humoral mediators. As I show you, we can use polymyxin hemoperfusion therapy for the absorption of endotoxins, but in the so-called sequential therapy today, we can also think to put in a series another membrane, such as PMMA membrane, hemophil, able to absorb cytokines, co-stimulatory molecules, and to inhibit complement factors, as well as the clearance of uremic toxins. Thanks.
Thank you, Vincenzo. So the session is open for discussion. Please come to ask questions. I invite Dr. Rieu to the stage so we can. There is one question, the first one, please.
Well, thank you for a very
Please
nice
introduce yourself.
Oh, my name is Rieu, and I'm from Denmark. It's a nice presentation. I was just wondering, complement is sort of a natural defense against sepsis. Is there risk of perhaps improving kidney output but killing the patient from sepsis by removing complement factors?
Sorry, can you repeat?
I said the complement system is sort of a natural defense against infection
Yeah,
and sepsis. So I was wondering if there's a risk of worsening infection while protecting the kidney.
Now, obviously, the complement is not only a bad effect, because the complement is essential for the response to infection. It depends on timing, obviously. However, also, not only in the experimental models, but also in the clinic, this is the same thing for using drugs able to inhibit the complements. But as Giuseppe showed you for ischemia perfusion injury, one of the pathogenic mechanisms of tissue damage during sepsis, in particular from the kidney, not only in the tubular compartment, but also in the glomerular compartment, is associated with a prolonged, chronic, and dysregulated complement response.
Yeah, most of the time is the overactivation of complement, like in the chronic hemodialysis, that leads to the damage. You are right, it's important as a basic defense, but most of the time there is overactivation, especially of the alternative pathway. For this reason, there is a lot of trying to therapeutic inhibit this overactivation of the immune system.
This is also the reason for which I try to show that there is not only the complement activation, this is an essential part, but obviously these membranes are able to modulate different systems and pathways.
I have a question for Dr. Rieu. Very nice presentation. So, in the clinical application, what do you think is the ideal patient for this membrane, for HydroLink?
So, I think the goal is to try to avoid anticoagulation during hemodialysis for many reasons. Because, for example, we know that the risk of bleeding, and the risk of bleeding should be also associated with an increased amount of heparin during dialysis. And also because when you have coagulation, you have activation of leukocytes, of platelets, so maybe it could have effects on cardiovascular events. So I think for the first step is to find a way to remove anticoagulant during dialysis. And after that, we can demonstrate that there is a benefit to remove anticoagulation during hemodialysis.
Thank you.
Question here.
Yes, thank you, Olivier Morin from France. Thank you for this interesting session. A question for Philippe Rieu about your interesting protocol. Do you plan hemodialysis, hemodiafiltration, and do you consider priming with heparin or pre-dilution with this specific membrane?
So it's not blind, it couldn't be blind, and there is no priming with heparin. And both can be used, hemodiafiltration and hemofiltration.
Thank you.
Hemodialysis.
So I have a question for Vincenzo. So you show once more that during sepsis, AKI, there is hyperactivation of the immune system, CD40 ligand triggered by LPS. But what is interesting is that if we modulate a circulation level, then you have tissue protection. Is it correct?
Yeah, no, but during sepsis, we had two different phases. The first is the hyperinflammatory phase in which you can have organ dysfunction, but you also to consider the second part of immunoparalysis that may also be concomitant. This is the thing that is not easy to understand because we don't really have some biomarkers of understanding the activation of the immune system. Yes, however, surely the definition of sepsis is a life-threatening disorder associated with a dysfunction of the immune system. So the word immune system has come in the definition, in the sepsis-free definition.
Okay.
May I have a question for both of you?
Yes.
The first is for you. The protocol, in the protocol of the studies, do you consider to use as dialysis buffer citrate or it's free to use, because obviously it may have some modulation of...
No, we cannot use a citrate buffer.
Okay.
Dialysis buffer.
And Giuseppe, you showed a slide in which there is the course of kidney transplant, including the failing kidney transplant. I mean, in my view, this is a very frail population because you combine immunosuppression with uremia-related disorder. And I really think that the moment of coming back to dialysis, to return to dialysis, is very difficult for the doctors as well as for the patients. But this is a very frame in which the cardiovascular event, the cardiovascular risk and mortality is very high. Do you think that this may be a potential target population?
Yes, we wrote a review some years ago about the return of these transplant patients in dialysis, and there are data in the literature that the cardiovascular risk of this patient is higher than the first phase when from chronic kidney disease they enter for the first time in dialysis. So these are patients at high risk, and I think this is another ideal population in we should use this kind of new treatment to reduce as much as possible the activation of the innate immunity and the coagulation.
No, as a general comment to try to summarize some aspect of both the chronic and the acute setting is I think that nowadays we are in an era in which we have the idea to see the removal of different molecules, both in the chronic as well as in the acute setting. Because surely in the acute setting we have many sorbents that are coming out, and that sorption probably will be one of the most important properties in which we could use. But the same thing is also in the chronic setting, in which we should go over the KT over V and looking from specific uremic toxins that we can remove with a particular membrane. I don't know if you agree or...
I agree. And the other striking thing that I see in this data is that we can reach an immune modulation. So with this new treatment, we have a different response of the immune system. And this is quite interesting to me, because in the past we were thinking about removing something. Here we are thinking about to modulate the immune system with a positive effect in our patient in terms of cardiovascular outcome, and the data that I show also in response to vaccination. I think this is one very interesting area of investigation in the future. I don't know if you agree also.
No, I agree with you.
Yeah, sure, I agree. And to give another comment, today we have also the technology to do this, because we looking also the monitor, but also the membrane. So it's an interesting era, because we have to study, obviously. We know that it's not so easy to perform randomized clinical trials in both our settings, in both the chronic and in particular in the acute setting, because they are very expensive. I don't know if I focus on the acute setting, probably we have also to change the idea of our endpoints, because we probably know that these extracorporeal blood purification therapies are not able to modulate the mortality, so to have an effect on mortality. And this is what our friends intensivists obviously see in their randomized controlled trials, because they have the patients in ICU. In our view, we work together on the AKI study group of the Italian Society of Nephrology. It's also very important to see what happens after ICU and hospital discharge, because it's different in my mind to have a patient after 1 year from the hospital admission with a GFR of 60 or of 30. So you need a follow-up also this patient. This is another important point.
Yeah.
And possibly the membrane and the extracorporeal blood purification. If the experimental data are true, probably we can modulate in the acute phase, trying to avoid the progression toward the chronic phase.
Absolutely, but the important point is the timing of intervention. We should use new biomarkers that are earlier than serum creatinine, indicating there is already tissue damage, and then we can start. In this way, I think we can protect very well the kidney. If we are too late, then the capacity to recover of the kidney maybe will be lost. So the other point for this new technique, I think, is the right point of intervention.
Any other question?
So if not, I would like to thank you all for this participation, and again to TORAY to support this meeting. Thank you very much, and continue with the Congress.